I'm Jamie. I'm one of the F2s working at Guy's Hospital at the moment. Today, we're going to be talking about haematemesis and PR bleeding, focusing on the A to E approach. Now, by the sounds of things, most of you have been to these lectures before, so I won't go through the A to E stuff in as much detail. And this is my last lecture of the series, and it's been great fun. Hope you've all enjoyed it. I'm not going to be doing any more in the near future, but I'll probably take it up again and a bit later on in the year. All right, so keep an eye out for that. Right, let's start. So A to E approach, we'll go through the causes of GI bleeds, both upper and lower GI bleeds, and sort of differentiating between the two, and then we'll just go through some cases. So A to E, obviously, systematic approach, particularly used in unwell patients. It's really useful, particularly if you're if a patient's really sick or if you're a bit flustered on the wards. It's a fantastic tool to use. Okay, particularly as an F1 or a junior doctor, escalate early. Make sure that you're comfortable in the situation. If you're not comfortable, get help. Okay, it's patient safety comes first. All right. So airway. Not particularly relevant for what we're talking about today, but still worth mentioning. If a patient's airway is blocked, you might hear some funny upper airway noises. There might be sort of stridor type noises, or might be complete silence, which is very worrying and probably needs an anaesthetist to see them as soon as possible. But in the meantime, you can use a head tilt chin lift and a jaw thrust to keep the airway as open as possible, as well as these airway adjuncts, which we've been through before. But number 1 is a Goodell, number 2 is a nasopharyngeal, number 3 is an eye gel, and number 4 is an endotracheal tube with the cuff on the end, so that it stays in place and prevents aspiration. Okay. Breathing. How does the patient look from the end of the bed? It's probably the most important thing. Do they look particularly cyanosed? Are they using accessory muscles? Is their work of breathing increased? What's their respiratory rate and their saturations? And then have a listen to the chest, make sure there's air entry bilaterally and good expansion, as well as thinking about any airway noises, any crackles there. You can percuss as well, particularly if you're concerned that there might be some fluid on the lungs, or a pneumothorax. And then if they've got an oxygen requirement, obviously give them oxygen, but also run an ABG, because you want to know firstly what their actual PO2 is, rather than just their reading on their SATs, but also you want to know what their carbon dioxide level is and if they're acidotic, because there might be a COPD patient who's retaining. Get a chest x-ray, make sure there's nothing serious or acute going on, and it gives you a better clue about what you need to treat. Circulation, much more relevant for today. So again, OBS, what's their heart rate, what's their blood pressure, gives you a good indication as to whether this patient is stable or not. Are they cool peripherally? Do they look really dry? And sort of what color are they? Are they very anemic and actually they're white as a sheet? And then examine them, have a feel of the pulse, get their cap refill time, have a good listen to their heart, and look at their legs. Are they passing urine? Is it very dark in color? All of that sort of stuff is really useful to know. Have they got a catheter in? And then get an ECG on any unwell patient, just to make sure that they're in, well, just to check what their rhythm is. Even if it's sinus tachycardia, it's useful to know. And then treat it. If they're hypertensive and tachycardic, they're going to need fluids. You can give a bolus, get a large cannula in 1 or 2 arms if possible, and there's enough staff there. And think about maintenance fluids afterwards. If they're losing blood, do they need blood there and then, or will they need blood in the future? So think about getting some blood sent off. And we'll talk a little bit about what's important there, and a blood gas as well. If you haven't done an ABG, just do a VBG with the gas, because you want to know their lactate, and also their hemoglobin if you're worried that they're bleeding. Okay. D, is I always think about their level of alertness, which includes, are they confused, are they unconscious? Get a BM as you should with any unwell patient. Look at their pupils in case, just to rule out intracranial pathology, and a temperature as well. Are they febrile? Because that gives you a better indication of what else might be going on. Is it more an infective process rather than something else? Okay. And then finally, E, I tend to think about any lines or foreign bodies that are there. So cannulas, central lines. Have they got a wound? What does their abdomen feel like? Do a PR, particularly important for the topic that we're discussing today. And then any rashes on the skin and neurovascular status of the limbs, if that's appropriate. All right. And then reassess, look at their history, look at their drug charts. What's their past medical history? Have they got previous bloods to compare their current bloods to? Is this a frail old patient that shouldn't be for resuscitation, or is this someone that actually needs to be, ITU need to be aware of them quite urgently? All right. So then today we're talking about upper GI and lower GI bleeds, okay? And the first thing I want to say is these are quite, they can be quite scary presentations, and quite right too, because they are, patients can be very, very sick with these things, okay? So it's really important that you take them seriously, and that you have this systematic approach, so that you can stabilize an unwell patient and think about what needs to happen next, okay? So upper GI bleeds, that tends to be your haematemesis, so blood in your vomit, and quite often it's frank. But also don't forget that upper GI bleeds will have blood in the feces as well, in the stool, and this is typically melena, okay? So it tends to be sort of digested blood products, and if you haven't seen or smelt melena before, you'll know it straight away. It is pretty foul. Lower GI bleeds rarely have blood in the vomit. More commonly, it's really bright red blood, and it's occasionally mixed in the stool, depending on how high up the bleed is, okay? So as a general rule, the lower down the bleed, the fresher the blood. And then investigations for upper and lower GI bleeds is particularly important. So a VBG is vital, okay? Firstly, it gives you a really quick indication of what the hemoglobin is. Now, it's not the most accurate hemoglobin in the world, but you're going to know if it's 140 or is their hemoglobin 60, okay, which is vital. A lactate as well gives you a really good indicator of how unwell a patient is. Obviously, it's a marker of anaerobic respiration, so it indicates when there is underperfused tissues, and it indicates multi-organ failure, okay? Get a full blood count so that you've got an accurate hemoglobin, and alongside that you need a clotting, and send off a group and save. Some trusts will need 2 group and saves, so just be aware of that. Someone else might have to take a group and save so that they can be processed. And a urea as well, okay, really important. Now, obviously, you're going to send renal and LFTs and all of that, but I want to highlight urea here because it's a very, very good marker of upper GI bleeds, all right? And the reason for that is, if you imagine there's bleeding into the GI tract, if you are in the duodenum or higher up in the stomach, where there's lots of digestion taking place, not so much the jejunum, ileum, and large bowel, it's mainly the duodenum and the stomach. When there's blood there, it gets digested just like your food would, and your hemoglobin, which is protein, so most of your blood is protein, gets digested down into peptides, and one of the byproducts of that is urea, which then subsequently gets absorbed back into the bloodstream through the bowel, as the contents of your food do. And that's why you get an increase in urea, and it's urea only is raised in upper GI bleeds rather than lower GI bleeds, because you need that digestive and absorptive process, okay? So it's a really, really important marker, all right? I hope that's obvious, and please ask any questions if you don't understand that. I can go through it again, all right? So yeah, I've just broken it down into upper and lower here. hopefully you've heard of all of these. Some of them will be more familiar to you than others. I'll just run through them quickly. So mallory-Weiss tear is typically a traumatic incident. You don't get a lot of blood. It's not really a great deal to worry about. Gastritis, esophagitis, obviously can be caused by lots of different things, be that alcohol, medications, some inflammatory processes. Ulcers, again, sort of in a similar vein to the gastritis and esophagitis. If there's enough damage to the lining of the gut, the gut can ulcerate. And if it's severe enough, can actually perforate, and that's where you get commonly duodenal perforations. Okay, that when a patient becomes very sick and they need to be taken to theatre as soon as possible. Varices is a big one. Okay, in your cirrhotic liver patients, okay, they get massive portal hypertension, and basically you get dilated veins. Particularly in 3 areas, just due to where the portal venous system runs, and that one of them is esophageal, so you get the esophageal varices. The other is hemorrhoids, so you get dilated veins within the anus and the rectum, and then the third one is around the umbilicus, and that's how you get something called caput medusae, which is sort of the snake's hair appearance that Medusa had, and you see that around the belly. I don't have a picture of that. Sorry, I should have put that in. But you can just Google it, caput medusae. It's very, very classic in liver patients. Okay, but varices are the esophageal dilated veins that can rupture and cause massive upper GI bleeds, very frank haematemesis. So they're very concerning. And then malignancy, all cancers can bleed, and they often upper GI bleeds. So if that's an esophageal carcinoma or a stomach adenocarcinoma, those can both bleed and cause upper GI bleeding. Lower GI bleedings, most commonly caused by hemorrhoids. You get fresh red blood, but also malignancy, be that the colon, the rectum, or the anus itself. You can get all forms of colitis, so you can get infective colitis, typically from a gastroenteritis, or ischemic colitis from one of the vessels being blocked off from a thrombus or an embolus. On the vein of ischemic colitis, you get inflammatory bowel disease. So that's either ulcerative colitis or Crohn's. Typically, ulcerative colitis can cause sort of a pancolitis, resulting in GI bleeds. Diverticulitis, common in elderly patients who get inflammation and infection of their diverticula. Proctitis is an inflammation of the lining of the rectum, and also fissures and fistulas, which tend to be around the anus. Okay, and I've put AVM as well in there, which is rarer, but they're arteriovenous malformations, typically congenital things that can cause spontaneous bleeds with not a lot of other symptoms. So onto the cases. Any questions, guys? Put them in the chat. More than happy to answer them. So the first one is a 48-year-old man who comes into A&E, and you ask to clerk him on the medical take. He says he's got blood in his vomit. So obviously a very concerning feature. So straight away you go to the A to E to just check to see how stable the patient is. Airway's fine, you're not concerned. Breathing, he is a bit tachypneic from the end of the bed, and he's got a couple of creps in the right base, and sats on air are 93%. Okay. So get a chest X-ray, which shows a bit of consolidation on the right side. Put him on some oxygen. You can just via nasal cannula, that's fine, just to maintain sats of 94. And then after that, you can move on to circulation, and you find that his blood pressure is 82, and actually he's quite cool peripherally with a low cap refill time, prolonged cap refill time, and he's tachycardic. Okay. At this point, it would be worth doing a VBG, okay, because you don't know anything about the patient, but he is unstable. Okay, so what I'd probably do if I found that blood pressure is the first thing you should do send them for all the things that we mentioned before, as well as a VBG, okay, and get someone to run that for you, all right? So the fluids are going in, and while that happens, you continue your management and look at D, and you find that he's a bit confused, but other than that, not a lot else, okay? So then exposure, and you go on to examine him and take a bit more of a history, okay? And you find out that he's had a few episodes of frank haematemesis. He says he's lost a lot of blood, and it's been quite scary. He's got some mild epigastric tenderness, and his liver's not palpable, and you do a PR and you find out that he's got melena, okay? Now, at this point, you get the gas results back and you find that his lactate is 4 and his hemoglobin is 84, let's say, okay? So what do we think the differentials are for this man? There's a couple of things that it could realistically be, but there's a few things that he could have going on. So he's hemodynamically unstable. He's got a low hemoglobin, haematemesis, and melena, okay? Anyone got any ideas what might be going on? No stupid answers. Yeah, very good. I really like that, Abu. Particularly with the epigastric pain, actually. Very good. Now, if he had mild epigastric pain, would you expect it to be a perforated ulcer? Not sure. If someone's got a perforated ulcer, they tend to be quite peritonitic because obviously they've got blood within their peritoneal space that will be causing irritation. But it is possible, and it could just present with mild epigastric pain. Anything else that this could be? Frank red haematemesis. Quite a large amount. Yes, very good. This man has varices, okay? And when you go on to take a bit more of a history, you note that he's a chronic alcohol user. He's got liver cirrhosis, which is why you can't feel the liver because it's cirrhotic, it's tiny. And he's been known to have this sort of thing before. He's had previous OGDs that have shown varices, okay? So what do we do? What would our next stage be? So I think at this point, if you know he's got a low hemoglobin of 84 and he's still actively bleeding, I think that would probably warrant the upper GI, the major hemorrhage protocol, to make sure you can get some blood in quickly. Okay, so I'd probably activate that and get some blood sent to you. It'll be O negative blood, and then you can get that in. Okay, and that'll help. Someone said upper GI endoscopy, yeah, or an OGD, esophago-gastro duodenoscopy. Yes, completely correct. This man needs one. However, there's a couple of things we need to do before that. The first thing is we need to stabilize the patient, because you cannot do an OGD on a patient that's unstable. That is a general rule, okay? We've sent the bloods off, that's all fine. The next thing we need to do is score the patient, okay, to work out how severe this could be, all right? Now, there's a couple of scoring systems we can use. One is the Rockall score, and then the second one is, this is what we've just been through, A to E, think about past medical history, meds, alcohol, PR we've talked about, scoring system we'll go on to, and then what else needs to happen. So this is the Glasgow Blackstrap score, which is the one I classically use. Everyone make sure when you go into F1, you've got MD Calc downloaded on your phone. I'll put it in the chat. You can also use it online. It doesn't have to be on your phone. Just have a Google and it's really good. It's got all the scoring systems you need, so you don't need to remember any of them. And it tots it up for you and works out what needs to happen, basically. It's a fantastic tool. So this guy, you note that his urea on his bloods is 12. He has a hemoglobin of 84, as we said. and his systolic blood pressure was 84, pulse was over 100, and he's got melena and he's got hepatic disease. Okay, so he is scoring very, very, very high. Okay, and needs an urgent OGD once he's stabilized. Okay, at this point you need to get the people in, well, probably earlier, but get the people necessary involved. So with the gastroenterologist you're speaking to, if it's overnight, you need to call the med-reg, make them aware of the patient. Anesthetics will probably need to be aware of them as well. Okay, they'll need an anesthetic review, because the OGD will probably be done in theatre if they're this unwell. Interpreting Glasgow Blackstrap score, basically, if it's 0, they don't need an OGD. If it's more than 0, they do. And if it's more than 5, they need it urgently. Okay, so that's worth remembering. Okay, so yeah, that's what this guy needs, and he goes on to have an OGD. Does anyone remember? Is this on the next slide? Yes. Yeah, so other treatments that they need, apart from obviously you're giving them fluids, you're giving them a bit of oxygen, you're giving them blood from the major hemorrhage protocol, you sent off all the bloods. So if you've got an upper GI bleed that you're suspecting is varices, they need a stat dose of a PPI, depends on the trust, but classically it's a omeprazole, and then they need an infusion over 72 hours that you can set up. They need terlipressin, which is a drug that's a splanchnic vasoconstrictor. So splanchnic just means blood supply to the gut, so the arterial supply to the gut. So basically it constricts all of that, stops blood getting to your esophagus and your stomach, or reduces the amount of blood going there, and therefore reduces the amount of bleeding. Okay, so it's a really useful drug. And endoscopy, as we spoke about. So then within the endoscopy, what the gastroenterologist will do is they'll find the site of bleeding and they will inject it with adrenaline to cause vasoconstriction locally, as well as commonly they use thermal treatment, so they just cauterize the area to stop the bleed. Okay, varices themselves can be treated with sclerotherapy, where you inject a medicine into the vein itself and it causes scarring of the vein and therefore reduces blood flow through it. And if you really can't control them with endoscopic management, they quite often require a gastrectomy. Okay, so that is acute upper GI bleeds. Do they need antibiotics too? Very, very good question. And yes, typically they do. Okay, and just IV Kermox, nothing too fancy. Okay, just to cover superimposed infection, and particularly for this bloke who had crackles in the lower base as well as consolidation, he's probably aspirated a bit. So you'd want something to cover for chest. Okay. So case 2, 19-year-old man comes in on the medical take. It's about 11 o'clock at night, and he said he's had some blood in his vomiting. So you look at him, he looks actually quite well. His airway's fine. There's nothing wrong from a respiratory point of view. And actually he's hemodynamically stable. Okay. He's alert. His BMs are fine. He's afebrile. His abdomen is really nice and soft, non-tender, and he appears a bit intoxicated to you, and he tells you he's been in the pub for a couple of drinks this evening. Now, in this case, this patient's stable, so the ATE is not as important, but you wouldn't know that unless you'd done it, and now you're more reassured and you can go onto the history and work out a bit more about what's going on. So you ask him about this vomiting, and he tells you it was a single episode. After a few drinks, he felt a bit sick and went to the toilet, vomited, and there was a bit of blood, streaky blood in the vomit. Okay, he says not a lot. Probably wouldn't fill. Probably about 10 mils. And he denies other symptoms. Actually, he's never had anything like this before. So as with all patients that have upper or lower GI bleeds, they need a PR, and it's normal, just some soft brown stool. You score him and he scores 0. Okay, so we are therefore not worried about him. We don't think he needs an OGD. What do we think is the most likely diagnosis, though? Yes, very good. Well done. So he has had an MWT, so a Mallory Weiss tear, and it's typically a small traumatic tear, often secondary to vomiting. Okay. And there's nothing that needs to be done about this apart from he just needs to be safety netted. That's the most important thing. So if he has any more bleeding, if it gets worse, if he develops abdominal pain, if he's any foul smelling stool or bleeding through the back passage, if he gets confused, all of these things, just make sure he's aware of and he knows where to go or who to call. Okay. So nice, easy one, that. Case 3, 64-year-old man with some PR bleeding. Okay. So thinking more about lower GI bleeds now. And you just ask to go and assess him, and you see that his airway and breathing are absolutely fine. Okay. And he looks okay. He looks fine. He's sat in his chair. He looks pretty comfortable. He's not particularly pale. He's hemodynamically stable. You do some bloods and you send a lactate off, and lactate's normal. It's 1.2, and his hemoglobin's 124. Okay, on the gas. Again, nothing seen on D. And then exposure. You do an abdo exam. His abdomen's very nice, nice and soft, not tender at all. Bowel sounds are present. And you do a PR, okay? And on the PR, you see there's a bit of fresh red blood. And he's got some external hemorrhoids that you can see, some skin tags. And it's not tender when you perform the PR, okay? So diagnosis I've obviously given it away, is hemorrhoids. And remember, hemorrhoids can be external, but they can also be internal as well. Internal are ones that typically bleed more, okay? But they're often difficult to palpate on a PR exam, okay? So what needs to happen to this man? So he needs more of a history, obviously, and you find out that he's had some PR bleeding on and off for the last 6 months. Okay. Now, at this point, painless abdomen and PR bleeding, the most likely diagnosis is hemorrhoids, particularly as he's got them on your PR exam. But you still can't exclude malignancy at this point. Okay. And that's why you need to ask about red flag symptoms. So typically weight loss being the biggest one. Has he become cachectic recently? Oh, sorry, does he look cachectic? Has he lost weight? Has he gone down belt sizes, clothes sizes? And does he get fevers, night sweats? Is there thinking about lymphoma? Has there been a change in his bowel habit? Okay, has it suddenly got more? Has he got more constipated, or has he got more diarrhea in the last few weeks? All these things are really important to make sure that you ask about, and make sure you document as well, to cover yourself. Okay. And there's no red flags. You're not particularly concerned. Oh, other red flag obviously is previous malignancy. So has he had a previous GI malignancy that would be indicative of recurrence? Okay. Thing about his past medical history, is he on any anticoagulants for AF, for example? Is he on antiplatelets for ischemic heart disease or previous stroke? Because those might be antagonizing the bleeding, and therefore making it worse. And so you can think about stopping those in the future. In terms of further investigations, you've obviously done a PR. His blood's come back plumb normal. You can think about doing a proctoscope, okay, just to have a look inside and see if there's any hemorrhoids. But ultimately, this man can be discharged without further treatment. Now, treatment of hemorrhoids, break it down like most things that you would treat into conservative, medical, and surgical, okay? So conservative management for hemorrhoids is things like tell the patient to stop straining on the toilet, because that's why they're getting worse, or why he's got hemorrhoids. Because obviously if you strain, you increase the blood flow, and the hemorrhoids themselves, which are just dilated veins, will get bigger. And tell him to drink more fluids, because likely his stool will be hard, and by drinking fluids, you can help with that process. Medical management. Let's go on to the next slide. Sorry, it's here. Medical management is typically laxatives to prevent straining. And you can use cream, like topical creams, but they tend to be more for anal fissures to prevent bleeds and pain, because pain is associated with anal fissures, whereas hemorrhoids tend to be painless. But remember that patients can present with both, okay? And then finally, surgical. So if it's really bad, conservative medical management hasn't worked, they're actually losing, their hemoglobin count is dropping over a number of weeks or months, and it's really bothering them. You can use sclerotherapy to cause scarring of the hemorrhoids. You can band them, so that's when you tie a band around the base of the hemorrhoid, and it cuts off the blood supply to it and eventually drops off. And you can do stapled hemorrhoidopexy, which is basically where you take out a small part of the mucosa of the rectum, and it subsequently acts by pulling up on the anal cushion, causing the hemorrhoids to be pulled up as well, and basically they become less of a problem. So that's treatment of hemorrhoids. Just very quickly, a quick whistle-stop tour. All right, and then fine. Any questions about that? Do let me know. And then finally, we have our fourth case, okay, which is an 83-year-old woman, so an elderly, frail lady comes into A&E from her nursing home with severe abdominal pain she's complaining of, and some diarrhea, which has contained some fresh red blood. And this has all been within the last sort of 4 or 5 hours, okay? Past medical history, she's a bit comorbid. She's got vascular path with diabetes and hypertension. She's a bit large, obese, and therefore has OSA. She's got some fibromyalgia reported, and she's got AF as well, okay? So you know that the airway is patent and trachea is central. Her SATs are a little bit low on Romer, and she's quite tachypneic, okay? Now, whether the chest is the cause for that is unlikely, because her chest is clear, but get a chest x-ray as well, because her SATs are low, and get an ABG. And you know that her CO2 is fine, although she is acidotic, and her lactate is 8. So get some oxygen on her with those SATs and move on to circulation. You find out her blood pressure is 88 and her heart rate is 116. So this lady is hypotensive and tachycardic, and therefore in shock, likely hypovolemic, considering she's having blood in her stool. She's dry. A CRT is 4 seconds, but heart sounds are normal, okay? Nothing from disability, and on exposure, you note that her abdomen is pretty tender, and this is worse on the left side. She's got a bit of guarding, but there's it's not particularly peritonitic, okay? There's no rebound tenderness or percussion tenderness. You do a PR and you see some fresh red blood mixed in with some loose stool, okay? So first thing to do here is we acknowledge that we've got an unstable patient, okay, and they need to be stabilized before anything else can happen. So hypotensive and blood in stool. Get a bit more history about the blood in the stool, and you find out that it's quite a lot of blood. At this point, you'd probably be right to activate the major hemorrhage protocol, as well as obviously sending off those bloods that include group and save, clotting, as well as a urea, just in case, and renal profile, liver profile, full blood count. The hemoglobin on her gas is 90. So, you know, that is still stable, but she is actively bleeding with a low blood pressure. So you're well within your rights to activate the major hemorrhage protocol. The blood's there for a reason, okay? Okay, now what do we, I might have given it away. Chuck in the chat what we think might be going on here. So sort of blood mixed in with stool, abdominal pain, hypotensive, that past medical history. Anyone got any ideas? It's actually quite a common condition. Okay, like that. Colitis, very good. Colitis is quite a broad range of things. It can be infective, it can be ischemic, it can be inflammatory. All right. But yeah, very good suggestion. AVM, yes, I like that, although quite often it's painless. And with AVMs, you get a lot of blood, which is good. Perforated diverticulitis, yeah, particularly in an elderly woman. And I said left-sided abdominal pain, really, really good. She's afebrile though. You would typically see a fever in diverticulitis. And if she'd perforated, she'd be more peritonitic, okay? A GI bleed due to NSAIDs, yes, although it would present with melena rather than blood mixed in with the stool. You might not get abdominal pain with that. And if you did, it would typically be epigastric. All very good. But on the lines of colitis, yes. So this is an ischemic colitis, okay? And the giveaway, everyone, is first of all, she's elderly. Typically, it's elderly patients that get it. She's got AF, okay? And AF, we all think about stroke as the main concern with AF, okay? And that's why they're anticoagulated. But you can get emboli anywhere with AF, okay? The emboli don't just go to the brain. Obviously, the carotid is one of the first branches of the aorta, but you can get emboli that fly off to the arms, to the legs, causing acute ischemic limbs, but also they can affect the bowel, and that's what's happening here. So it's tricky to say where exactly there is a blockage in the artery. And that's why you need to do a CT scan, which is on the next slide, and I'll show you here. Now, radiologists hate this because quite often they don't show anything. So you want a CT abdo-pelvis to rule out other causes. So things like perforated diverticulitis is a prime example of something you're trying to rule out, as well as malignancy. But you want one with contrast to work out if there is a blockage in any of the arteries and therefore an ischemic colitis type picture. Okay. Now, radiologists hate it because to pick an ischemic colitis, you need them to be actively bleeding. And the chances of that are actually quite slim unless you've got a properly active bleeding vessel, sorry. And in the case of ischemic colitis, obviously the blockage itself is within the vessel, so that they're not likely to be bleeding very much. That would be more for an AVM type picture, okay? But you need to do one anyway. And that's because you're looking for a thrombus as well. And I don't know if you can see my mouse here, but we've got the vertebral body there. This is an axial plane, a transverse plane. And on the right side of the abdomen, you've got the liver. On the left side, you've got the bowel, typically, aorta here, and up here you can see the SMA coming off the aorta. SMA being the the second branch to the bowel of the aorta, and this grey stuff within here is clot. Okay. Now, the radiologist will grade how occluded the vessel is. If it's fully occluded and you have no blood flow through the SMA, that's really worrying because it will knock out everything from the second part of the duodenum all the way through to the two-thirds of the way along the transverse colon, which is a massive portion of bowel. And if you've lost that and it needs resected, particularly in an elderly, frail patient, it's often not compatible with life. Okay. If it's a partially occluded block, the area that tends to be affected most is the area that's most distal from the blood supply, and they're typically called watershed areas, and that is often the splenic flexure. Excuse me. And that's often why you get the left-sided abdominal pain typically. So if you see a thrombus like this, you can treat it with treatment dose dalteparin, or but more commonly you need to get the vascular surgeons involved to perform an embolectomy and and they can actually go in and remove the embolus itself. But what's important to be aware of, if we just go back to the patient, this is a very comorbid patient, 83, frail, from a nursing home. A massive operation like this is probably not likely to be successful. Okay, so it needs to be discussed with the medics and the surgeons because this patient is likely going to be palliated. Now, I think it's something like 75 to 80% of ischemic colitis results in mortality. Okay, so the chances aren't great to begin with, and when you've got that level of comorbidity and frailty, it's the most appropriate decision is to make the patient comfortable, get palliative care involved, and make sure the relatives are aware of what's going on and understanding of the reasoning behind your decision. Okay, so that is the fourth case. Fine, thank you very much everyone for listening. I will pop the feedback form in the chat, but there's a QR code there for you all. Let me just get back onto it. And thanks for listening over the past few weeks. It's been very enjoyable. I hope you guys have enjoyed it, and I hope you found it useful and it's tied in with your curriculum that you've been doing at various med schools around the country. And the slides will be sent to you in due course. So yeah, if you could fill the feedback form in, and then you're free to go. Thank you. I'll hang around for a bit just in case there's any questions. When will the recording be uploaded? Very good question. I'm not sure. I'll make sure Azim is aware and hopefully get it uploaded quickly. All right, along with the slides.